Part 2 of the lecture on neck anatomy focuses on cervical lymph nodes. Now let's turn our attention to perhaps the most important thing that we look at anatomically in the neck, and that is the cervical lymph nodes. They're so important because a lot of the work we do in the neck is cancer work, and metastatic disease to cervical lymph nodes is a core part of that analysis. We'll talk about the anatomic organization of the lymph nodes. We'll talk about the way we break them up anatomically and contrast that with the way we break them up surgically into the surgical zones. And then we'll spend some time talking about how we decide whether a lymph node is benign or malignant. Anatomically, the lymph nodes in the neck are divided into clusters, which are named after the space that they're in. We've talked all about those spaces, and chains, which are named after the structure that they accompany, whether it be an artery or a nerve or a vein. The node clusters that we're familiar with include the submental cluster, which, as you might imagine, is in the submental triangle, the submandibular cluster, which lies anterior to the submandibular gland in the submandibular triangle, and the retropharyngeal clusters, which lie in the true retropharyngeal space. The major node chains include the internal jugular chain that accompanies the internal jugular vein, the spinal accessory chain that accompanies the spinal accessory nerve, the transverse cervical chain that accompanies the transverse cervical artery across the base of the neck anteriorly, the external jugular chain, which follows the external jugular vein across the top of the sternocleidomastoid muscle, and the juxtavisceral chains that run down the front of the strap muscles. The three that are really going to be most important to us are the internal jugular chain, the spinal accessory chain, and the transverse cervical chain, because these three form a triangle in the neck that is the basis for all of this nodal anatomy. So here's a drawing showing all that anatomy we've just been talking about. Here, for example, is the submental cluster lying medial to that anterior belly of the digastric. Here is the submandibular cluster between the anterior and posterior bellies of a digastric muscle. You see some additional smaller clusters like facial nodes and parotid nodes and occipital nodes, and they all flow down into this long chain of nodes that lies deep to the sternocleidomastoid muscle, right along and intertwining around the internal jugular vein. That's the internal jugular chain. You can see the spinal accessory chain is the other thing that comes off and near the skull base, but this one travels obliquely across the posterior triangle and runs deep to the trapezius muscle along the spinal accessory nerve. And the bottoms of those two, although they're headed in different directions, their bottoms connect up with the transverse cervical chain. This is that triangle of lymph nodes that I was talking about that is at the core of our nodal anatomy. The juxtavisceral nodes out front in the neck come down and join that transverse cervical chain. Now, having looked at that anatomical organization of the lymph nodes, we're going to superimpose on that a whole different structure, which is the surgical division into levels or zones. The reason that we do this is because we want to make sure that we have reproducible lymphadenectomies, that if somebody is taking out a level 3 lymph node in Los Angeles and someone is taking out a level 3 lymph node in Pittsburgh, they're both talking about the same thing. Here's how it works. Level 1 is the nodes in the submental and submandibular chain. If you want to break it down into 1A and 1B, you can. Level 2 are the nodes near the skull base in the superior aspect of the internal jugular chain and the superior aspect of the spinal accessory chain. Once you get to the center of the internal jugular chain, that is going to be level 3. The bottom of that internal jugular chain and about half of the transverse cervical chain, that is level 4. And you have to go posteriorly into the posterior triangle here to catch the bottom half of the spinal accessory and the back half of the transverse cervical chain. That's level 5. Level 6 are these previsceral nodes running down the front of the neck. So this is the surgical system superimposed on top of the anatomic structure of nodes in the neck. Now let's run down more precisely what the radiologic boundaries are that define these different levels or zones in the neck. The submental and submandibular triangles are pretty well defined based on the fascial arrangements that we've already discussed and the muscular arrangements we've discussed. So that's zone 1. Zone 2 are those nodes that are above the level of the hyoid bone, but are not in the posterior triangle of the neck. Above the level of the hyoid, that's level 2. Level 3 runs from the hyoid bone to the bottom of the cricoid cartilage. If you think about it, that kind of corresponds to the larynx, right? Hyoid bone to bottom of cricoid, that's level 3. Level 4 is below the level of the inferior to the bottom edge of the cricoid cartilage. Level 5 is posterior to the sternocleidomastoid muscle. And I don't mean deep to the sternocleidomastoid muscle. I mean posterior to the sternocleidomastoid muscle. That's a very important distinction. Level 6 are anterior lymph nodes in the midline of the neck. They should be medial to the carotid arteries. Let's run through some examples of those. Here is a large lymph node. You can see that it is just below the level of the jaw, and you can see that it is medial to that anterior belly of the digastric right there. There it is on the unaffected side. That anterior belly of the digastric, that puts it in the submental triangle. So this is a submental lymph node, level 1. How about all of these nodes here? Well, this is the submandibular gland. So these nodes right next to the submandibular gland, those are going to be submandibular lymph nodes. In particular, nodes that are anterior and lateral to the submandibular gland are in the submandibular triangle, level 1. Well, hang on, what about this node here? This is an enlarged lymph node. It's right next to the submandibular gland. Why didn't it have an arrow on it? Isn't this also in the submandibular triangle? No, this one is not. If it is posterior to the submandibular gland, you are now into level 2. So if you are anterior or lateral to the submandibular gland, you get to be in level 1, more specifically level 1B. If you are posterior to the submandibular gland, you are in level 2. I'm going to re-emphasize that concept a little more. This arrow is on the submandibular gland itself. This vein is a really useful anatomic structure. This is a branch of the anterior facial vein. And this anterior facial vein runs right between the submandibular gland and the submandibular lymph nodes. So if you can find that vein, you can see by its displacement whether a mass arose from the node, the submandibular lymph nodes, or whether it arose from the submandibular gland, which can be really useful for a mass in that location and you're not sure where it came from. So this node, anterior to the sternocleidomastoid muscle, is a level 1 lymph node. This node, posterior to the submandibular gland, is a level 2 lymph node. Okay, we're moving down a little bit in the neck. Here we are just on the anterior medial aspect of the sternocleidomastoid muscle. Where are we vertically? Well, this is the thyroid cartilage. Here's some arytenoid cartilages. We're in the larynx. We're next to the larynx, so we must be in level 3 of the neck. Going down a little further, here's some thyroid gland. We're outside the larynx. We're down at the base of the neck. We're inferior to the larynx. This is going to be level 4. Here we are, still down low in the neck, below the level of the larynx. This guy's had a laryngectomy, makes it a little more challenging maybe, but here we are, look where we are relative to the trapezius muscle. We're down low in the neck. This is the posterior triangle. This is level 5. We are posterior to the sternocleidomastoid muscle, right? There's the sternocleidomastoid muscle. We're posterior to that. We're in the posterior triangle. We are in level 5. How about this guy? He's in the posterior neck, right? So probably a level 5 node. But wait. We said you had to be strictly posterior to the sternocleidomastoid muscle. If you're unsure, draw a line between the posterior edge of one sternocleidomastoid muscle and the posterior edge of the other sternocleidomastoid muscle. That line is the dividing line between levels 2, 3, 4 and level 5. So this thing is anterior to that line. It's not in level 5. Level 5's back here. This, because we're so high up in the neck, we're above the level of the hyoid. That's the jaw. We're above the level of the hyoid. We're still in level 2. That's a level 2 lymph node. Here's a lymph node in the previsceral space. Here are the strap muscles. It's anterior to the strap muscles. It's medial to the carotid artery. These are the previsceral lymph nodes, sometimes called Delphian nodes, some of them. And this is considered level 6. Now, I've gone through a list of the levels of lymph nodes in the neck, and I've done them in numerical order, but that's not actually how I think about them. I think about them in perhaps in non-intuitive order that helps me avoid mistakes in classification. So here's my scheme for when I'm classifying a lymph node in the neck. First, I ask myself, is it under the chin? And if it's right under the chin, it's going to be in level 1, zone 1 if you like. Level 1, right underneath the chin. Okay, that's easy. But then I jump down to level 5. And I ask myself, is it posterior to the sternocleidomastoid muscle? Because if it's strictly posterior to the sternocleidomastoid muscle in the way we showed on that previous slide, then it's in level 5. And that prevents me from making the error of putting something into level 2, 3, and 4, depending on how high up it is, without having checked to see how far posterior it is. Only then, after I've thought about level 5, do I go back and say, is it above the larynx, next to the larynx, or below the larynx? And that puts it in level 2, level 3, or level 4. You have to be a little careful when you're using other modalities. What I've talked about works for the surgeons, although they use different boundary anatomy, and it works on CT and MRI, but there's some different rules in sonography. The sonographic classification uses different radiologic markers. There's more than one sonographic scheme for classification of nodes. And be careful because radiation oncologists have their own schemes that they can apply. So be a little wary when you see other people classifying nodes, but I think in speaking with the surgeons, they'll all be comfortable with the scheme that we have been talking about so far. There are lymph nodes that don't fit into these surgical levels. These are particularly important to the radiologist because if we don't find these, no one will. The surgeons aren't looking for them. They're not taking them out in the operating room. It's our job to find these. And these include facial lymph nodes, occipital lymph nodes, and retropharyngeal lymph nodes. At first glance, you might look at this lymph node and think, well, that's a submandibular lymph node, right? It's a little lateral and right under the chin. But it's not right under the chin. It's lateral to the jaw, not underneath it, right? We are not submental here or submandibular. We're not below the mandible. We're next to the mandible. This is still the face. And this is where facial lymph nodes arise. Facial node next to the mandible. Here's a couple of lymph nodes that aren't far enough down in the neck to even get into these surgical zones. These are right under the occipital bone, and these are occipital lymph nodes. These often receive metastatic disease, say, from scalp primaries. You have to really be looking for these specifically, or you'll go right past them. Where are these lymph nodes located? Well, we've already talked about how the displacement of the parapharyngeal fat is useful in these situations. This is lymphadenopathy in the retropharyngeal lymph nodes. And those are particularly associated with nasopharyngeal carcinoma. There are a few lymph nodes that get special names: the jugular-digastric node, the node of Virchow, and the node of Rouvier. This is the jugular-digastric node. It lies right at the boundary between level 2 and level 3. It's important because it can be much larger than its counterparts even when it is normal. People who like thresholds will use 1 centimeter long axis diameter for most nodes in the neck, but they'll allow the jugular-digastric node up to 1.5 centimeter because it's often just a little bit bigger. This is the node of Virchow. The node of Virchow lies at the bottom of the internal jugular chain, or if you like, the most medial aspect of the transverse cervical chain, right in, it's in level 4, right where those two anatomic chains meet. The node of Virchow is important because it can receive metastatic disease from distant sites without intervening lymph nodes. We like to think of nodal spread as going one node, then the next node, then the next node in order. So if you have an abdominal primary, it should march its way up through the mediastinum before it reaches the neck. But the node of Virchow can bypass that. It can short circuit it, and you can have lymph nodes from abdominal and pelvic malignancies that present as lymphadenopathy in the neck without anything going on in the chest. When you see lymphadenopathy in the node of Virchow and you can't find a primary, you need to scan the abdomen and pelvis, even if the chest is negative. The node of Rouvier is an eponym for the most superior of the retropharyngeal lymph node chain. It lies about 2 centimeters below the skull base, and we usually don't see lymph nodes higher than that, closer to the skull base. So if you see something you think is a lymph node right up against the skull base, maybe think twice about that. Let's talk about how we as radiologists distinguish between benign and malignant lymph nodes. There are many criteria that have been used in the literature to make this distinction. It's hugely important. It's much of what we do in neck imaging. One way you can tell the difference is by size. Larger lymph nodes are more likely to be metastatic. Different authors have used different thresholds as criteria for malignancy. Different authors have used long axis of the node versus short axis of the node, and cutoffs include 8, 10, or 15 millimeters for the nodes in the neck. In other areas of the body, most people like to measure things in short axis, but in the neck, it's usually better to measure something in the long axis because the neck is different from the mediastinum because people can feel the lymph nodes in the neck. So if you talk about a 1 centimeter lymph node and they're like, oh, I can feel this thing, it's 2 centimeters long, it sounds like you might not be talking about the same thing. So I prefer to report long axis, particularly in neck nodes. Another way that you can distinguish them is degree of enhancement. Malignant nodes enhance more than their benign counterparts, and you can use other nodes in the neck as references. Be a little careful because after radiation, lymph nodes enhance a bit more. There are other things that can cause increased enhancement. Certainly, inflammation does, but it's a great way of distinguishing. Homogeneity, benign nodes tend to be very homogeneous. They may have a central vessel running into them, but their parenchymal pattern of enhancement is very homogeneous. If you see heterogeneous nodes with decreased enhancement centrally, that's necrosis, and it doesn't matter how small that node is. If you see necrosis, it is malignant. Now, there's a caveat here that you're not just looking at partial voluming of the normal central fatty hilum. Don't be fooled by that. But if it's truly necrosis in the center of the node, that is malignancy. Configuration, this is my favorite. My favorite criterion is configuration. Normal nodes have a reniform configuration. They are shaped like kidneys. They have a central hilum, they have fat headed into the hilum, they have vessels headed into the hilum, they are reniform. Sometimes that's hard to appreciate on a single axial cut if the lymph node is oriented vertically and you get a cross section that doesn't show you the hilum. But if you take the whole thing together, you should be able to find a hilum and a reniform configuration. Spherical nodes are abnormal, and malignancy tends to form spherical nodes. So if you see something that is truly spherical, that is more likely to be malignant. Borders, if you see irregular borders, if it's not a well-defined mass, that not only suggests malignancy, it even suggests extranodal extension outside of the node itself, so a very aggressive tumor. So which of these is the best criterion for neck nodes? Well, people argue about it. By far, the one that gets published most is size criteria because it is quantitative. It's hard to argue when you put a ruler on a CT scan. But in my opinion, it is the least useful of these criteria. I don't like size criteria. You can have inflammation causing very large nodes. You can have small nodes that are malignant. Although it is the most common criterion described in the literature, it is my least favorite way to distinguish between benign and malignant nodes. A radiologist with a ruler is in trouble. How about this node here? It's not particularly large, maybe a centimeter, but it's really enhancing a lot. It's enhancing more than the other nodes that we're seeing on the other side of the neck. That enhancement is worrisome, and this is in fact recurrent metastatic disease in the neck. By the way, everything that I'm going to show you is path proven. How about this node here? It's tiny. It's like 4 millimeters. By anybody's size criteria, this is a benign node. But it has rim enhancement. It has a necrotic center. This is a necrotic lymph node. This is malignancy. This is metastatic disease in this tiny, tiny node. Here's a lymph node with very poorly defined borders. I can't tell you where that lymph node ends and where the sternocleidomastoid begins. All of the fat planes between the vessels here have been infiltrative. This is a metastatic lymph node and in fact a lymph node with definitive extranodal extension. How about these guys here? Not particularly big, 5-6 millimeters, tiny nodes, but there's a cluster of them. That's a little worrisome. And they're rounded. This rounded configuration is concerning. Even small nodes should be reniform. And like I said, a single cut, it's hard to judge them by, but I'll tell you that if you go up and down on consecutive cuts, they are truly spheres. Spherical nodes are likely to represent metastatic disease, as these two did. How about this guy? He's pretty big. I mean, put a measurement on that. He's going to be 2 centimeters in overall size. By anyone's size criteria, that's malignancy. But it's obviously not. It's a reniform node. It's got a huge fatty hilum. You can even see the central vessels going in. There's no increased enhancement in this thing. It is a completely benign configuration, a completely benign appearance, despite its size. The configuration way more important than the size when evaluating this node. How about this guy? This guy is huge. I mean, that's like 3 centimeters worth of lymph node there. It's a monster. That's got to be malignancy. But it's not. Even though it's asymmetric, it's still reniform. Even if the top half's bigger than the bottom, it still has a fatty hilum right there. This is a reactive lymph node. I mean, yeah, you can see that this guy's got an infection going on above that, and this is a reactive node. So there's other clues here as well. But that reniform configuration is really important. Be careful when you see a reniform configuration that even a large node, you don't just jump to malignancy. That concludes the section of this talk focused on the cervical lymph nodes.